good morning to everybody. So, who is presenter? Ankit Rai,
Yes, sir.
Yes, sir.
Good morning, sir.
Jo Jodhpur. Huh?
Yes.
Okay, Ankit, let's start. Okay.
Good morning, sir. I'm presenting the case of Mrs. Andy. She's a 58 years old female homemaker from Jodhpur. She presented to us with the chief complaint of difficulty in swallowing food for the last 1 month. So, patient was apparently asymptomatic 1 month back when she developed insidious onset of difficulty in swallowing food, which was more for solids than liquids, and she had complaints of sensation of food getting stuck in her mid chest. This was painless and has progressively increased from initially when she required water to swallow the food, and at present she is not able to tolerate solids and is on semi-solid diet. This is also associated with regurgitation of undigested food particles within 5 to 10 minutes of meals. She also has history of non-documented weight loss. However, her appetite is preserved. She does not report any history of odynophagia, neck pain, or any neck swelling. There is no history of nasal regurgitation, dysarthria, or nasal twang. There is no relation of her complaints with hot or cold meals. There is no history of chronic cough with expectoration or recurrent URTI. There is no history of heartburn or chest pain. There is no history of hematomesis or melena. There is no history of corrosive ingestion. There is no history of any recent change in voice, coughing or choking after meals or backache. And there is no history of headache, seizures, shortness of breath, hemoptysis, abdominal distension, bone or back pain. For these complaints, she was evaluated at MDM Hospital in Jodhpur, and where multiple endoscopic evaluation and biopsies were done, and she was referred for further treatment to us. She does not have any history of similar complaints in the past, and there is no history of any chronic illnesses such as diabetes, hypertension, thyroid disorder, or coronary artery disease, and she does not have any previous surgical history. There is no history of change in bladder or bowel habits. There is a history of betel nut chewing for the last 5 years, which she stopped 1 month back. Her sleep is undisturbed. Gynecological history: she has 2 children. She attained menopause 5 months back, and there is no history of any postmenopausal bleed. Family history is not significant. So, my summary is a 58-year-old female who presented with complaints of insidious onset, painless, progressively increasing from grade 1 to grade 3, difficulty in swallowing solids more than liquids, with a sensation of food bolus stuck in mid chest, associated with regurgitation of undigested food particles and unintentional weight loss.
Okay, Ankit. Now you go to the slide where you have written multiple no history, no history.
Yes,
Can
sir.
I go to that slide?
Yes, sir.
Hmm. So why are you saying odynophagia, no history?
So, basically, I want to rule out any local cause which might cause dysphagia, like any pharyngitis or tonsillitis, and any neck abscess, any retropharyngeal abscess, which can cause dysphagia.
Okay. And what about go to the next one? No, last one, sorry, last one, just before this. So what about the chronic cough and expectoration?
Sir, in motility disorders, actually, because of microaspiration, patients may develop chronic cough expectoration. They may have symptoms of recurrent URTI.
Okay, so it's not possible. In which way, in which particular, in which of the benign you are talking about, where it is more common chronic cough expectoration, the recurrent event?
It's common with achalasia, sir, when there is sigmoid esophagus. And
Yes, so it's very important. Is the dilatation goes on, and they might have. And
yes.
what about this hot and cold meals?
Again, this is common with motility disorders. Even with achalasia cardia, this can be seen.
Okay. So next slide, next one, please.
Yes.
Show the next one. So why are you saying this? There is a choking, coughing, and choking.
This is to rule out if there is any tracheoesophageal communication. After swallowing, she might develop these symptoms.
So it's very important to understand if there is a any type of choking occurs because of the tracheoesophageal communication that might produce this type of symptoms. Okay. So go back, go to your summary, please. So this is a 58 years lady, this thing. So what is why you say there is a history of taking betel nut?
Sir, that is one of the risk factors for carcinoma esophagus.
So what is that thing which is present in the betel nut? What type of chemical is present? It's not the nicotine as it happens in a smoke.
Yes, sir.
So betel nut contains what? Are you aware?
No, sir.
So where it has been mentioned that betel nut is basically more of Indian food, Indian thing, something. So
Yes, sir.
have you got any Indian this thing regarding this? I'm just asking.
I'm not aware, sir.
You are not aware. So i- can you mention anything which can which you have not mentioned in the history, which can be important in terms of uh, this CA esophagus, where there are two components. If you are thinking about which can probably you are talking about. If I will ask, you will say that my first diagnosis is carcinoma esophagus because of certain reasons.
Yes,
So,
sir.
in the same context, can you think of the some diseases? We are predisposing factors. We lead. There are two components to CA esophagus. One is something which is a risk factor, and
Yes,
another is where is a presentation of the pre-malignant lesions. Is
yes, sir.
there any type of, did you ask any type of this type of history where you can have some leading point other than betel nut?
Yes, sir. I asked for heartburn and chest pain. These are typical symptoms of GRD, sir. So it
Huh.
could be a predisposing factor for adenocarcinoma.
Okay. So more of a GERD people might have this type of thing. And any other thing?
Sir, regurgitation actually patient has the complaints, but
Uh,
this symptom is also present for the last 1 month only. So if
uh,
it is associated
so
with GRD,
long-term GERD. And what is the typical site when you are thinking about GERD? Typical site of the malignancy?
it is lower one third of the esophagus and G
Sure.
junction.
Sure, you have read about this syndrome after when there is a changes in the esophagus. What is the typical site? Is it clearly lower esophagus or something else?
With GRD, it is lower esophagus.
GERD when leading to the what are the sequence of events?
So it will lead to squamous metaplasia, sir.
Uh,
From the columnar epithelium will change to squamous epithelium, so squamous metaplasia. And
Okay,
Barrett's esophagus will develop, and then it will first go into low-grade Barrett's esophagus with low-grade dysplasia, then high-grade dysplasia, and then invasive adenocarcinoma.
so you mean to say in Barrett's most of the time it will be squamous cell carcinoma.
No, sir, it will be adenocarcinoma.
Then why are you saying it goes to squamous metaplasia?
Sir, uh, the squamous epithelium is the normal esophageal lining is the
Mm.
squamous epithelium that is
Yes.
replaced by the.
So, so it is not that very typical lower esophagus. It may be little bit higher up. When you see the Barrett's, it's not very typically like a G junction. It's a little bit higher up, and adenocarcinoma can happen in Barrett's. So it's
Okay.
very important to 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 look into all these factors. Any other thing? Suppose somebody she says that I had very typical anemia. I used to have typical anemia, multiple times breathlessness episodes, chronic anemia. Can there be any correlation?
Fanconi's anemia is a risk factor for.
So that's why I was saying, what about leukoplegia?
Sir, it is a predisposing factor for squamous cell cancer, sir.
Yeah. So what I want to give a hint that in a patient where this history is so clear, almost clear, then I
Yes.
think you have tried to look into benign causes, but other things also must be this thing. Can you think of the any other thing where there may be compression and the same type of symptom can occur?
So in neck, like sometimes Zenker's diverticulum can cause, but that leads to usually oropharyngeal
So
dysphagia.
that doesn't look like this type of symptoms. Doesn't look like that. There is no other things which are suggesting that.
Yes, sir.
So suppose somebody has a pulmonary nodal tuberculosis.
Yes,
Do you
sir.
think esophagus can be compressed and there can be weight loss?
Yes, it is possible.
It is possible, but this type of history usually not present. So what I mean to say that all these things we should try to look into that and then these things. So benign causes you have almost this thing tried to exclude each and every cause. But achalasia cardia, is it a predisposing pre-malignant condition or not?
Yes, sir. It predisposes to squamous cell cancers.
So this is also very important. So all these things are very very important. We should be knowing all these things. And um, so then what is your first diagnosis?
So my first differential is carcinoma esophagus, sir. And,
Okay,
I would like to keep.
carcinoma is. So by any chance, can you think of other achalasia cardia? We have written second diagnosis. Is it in association of carcinoma esophagus, or you think that it is achalasia cardia alone?
So it could be achalasia cardia with second with malignant transformation into carcinoma esophagus.
But what is the typical age for the achalasia cardia?
Usually, it presents at a much younger age.
Yes. So these are for the discussion point of view. We should know all these things. But otherwise, it's looking very clear. Peptic stricture you have written.
So because she had history of regurgitation, so maybe she had some
So
component of GRD and
So there are two
lower.
type of reflexes which can produce peptic stricture, which can produce more commonly peptic stricture living very asymptomatic for a long time. Which reflex is more prone to develop peptic stricture, lower esophageal stricture.
Acid reflux.
Acid is I think you must understand the esophagus is usually pH is alkaline.
Yes, sir.
So esophageal mucosa is friendly to the alkaline pH.
Yes, sir.
So damage go on occurring. In contrast, if there is acid pH, which is not esophageal mucosa, not friendly, symptoms occur much earlier. So you go to take a treatment. But if there is alkaline gastric reflux, which is rare, but because of the friendly mucosa and very little symptom, and people might go to benign stricture, but there is no loss of appetite. Why do you think it is like that? You said there is a weight loss,
Yes,
so
sir.
that anybody can say that weight loss might have occurred because of the inadequate intake. So what about if I say that weight loss is because of this, still I can think of benign disease. What is your objection?
So the duration of her complaints is short duration, so it's just 1 month.
Very short duration and progressively increasing. So
Yes.
that is also very, very important, that there is no other symptom which is for a long time. So let's go to examination, please.
Yes, sir. So on examination, the patient is a middle-aged female. She has average build with a height of 163 centimeter, weight 50.8 kg, and a BMI of 19.1 kg per meter square. She's moderately nourished. Her ECOG performance status is 0.
Mhm.
Patient was conscious, cooperative, and well-oriented to time, place, and person. Her vitals at the time of examination were a pulse of 75 per minute, blood pressure of 130 by 82 millimeters mercury, saturation 100% on room air, and she was afebrile to touch. On head-to-toe examination, she had flattened cheeks and supraclavicular hollowing was noted. There was no pallor, icterus, cyanosis, clubbing, or pedal edema. There was no palpable cervical lymphadenopathy. On oral cavity examination, mouth opening was around 5 centimeter. There were dental caries and stain marks. There was no ulcer or leukoplakia. Coming to systemic examination, abdomen was flat, umbilicus was central and inverted. There were stria marks in the lower abdomen and a non-airy mole was noted in the left hypochondrium. There were no scar marks, hernial orifices were normal, and there was no renal angle fullness. On palpation, the abdomen was soft and non-tender. There was no palpable organomegaly. Hernial sides were normal. There was no renal angle or spine tenderness. Percussion, the liver span was 12 centimeter and there was no free fluid. On auscultation, normal bowel sounds were heard. On digital rectal examination, mucosa was smooth with fecal staining. respiratory examination, the trachea was
So
mid.
in the abdominal examination, I'm sorry to interrupt because we might miss it. So if you go and then I start in abdominal examination, which area is more important in a carcinoma esophagus? Where do you think you should give a very much thought, and might be there may be something might be palpable other than liver and spleen you have mentioned. So can you think that there may be when you are examining abdomen in a patient who is so thin, only BMI low, only 50 kg, with a height of 163 centimeter,
Yes, sir.
can you palpate some nodal nodes?
So if they are significantly enlarged lymph nodes, then yes, sir.
So how do you know that there is no significant enlarged lymph node? So I think it's very important to give a hint to the examiner who is listening to you that I know this thing and I have tried to look into that. Go ahead.
Respiratory system examination on inspection, trachea was in midline. There were no scars or sinuses. Bilateral chest movement was equal. The breath holding time was 21 seconds. On palpation, trachea was central. There was no local tenderness. Bilateral chest movements were equal. On percussion, bilateral uh, notes were resonant, and on auscultation, bilateral normal vesicular breath sounds were heard. There were no added
So
sounds.
Ankit, what is your expectation? What do you think that can be found finding which can occur in a patient of say esophagus in chest?
Sir, if there is a advanced tumor which is either compressing or causing compression of the
Hmm.
respiratory tract, then it can cause tracheal deviation.
That
And,
is important, very important. And
and in patients who have advanced or metastatic disease, if they have pleural effusion, then air entry may be decreased. Uh,
so I
and
think basal crepitations, there is no why crepitations are important. You have not mentioned. That's why I asked you.
so there is no added sound image.
Okay. So 100 signed okay, but I think we should be why there can there be crepitation?
Yes, sir. One, it could be because of pleural effusion, sir. And
Uh-huh.
apart from that, in patients who are having recurrent microaspiration,
Yeah.
those patients may also have fitness.
These patients have bronchiectasis?
Sorry, sir.
Bronchiectasis, can these patients have bronchiectasis?
Yes, sir. Because if the patient is having recurrent aspiration, then chronic bronchitis can predispose to bronchiectasis.
When you are talking of chest, unlike any other abdominal or GI malignancy, in a esophagus malignancy, we must try to touch these areas so that person listening to you knows that you have tried to see all these findings. Go ahead.
Come to investigation.
Hmm. No. So now, was anything added by the examination in terms of reaching to the diagnosis?
Sir, her nutritional status was
Uh,
assessed, which it was
uh,
moderately nourished. And apart from that, oral hygiene was poor. There were dental caries and
uh.
there were stain marks. And other features of malnutrition like flattened cheeks and supraclavicular hollowing was also present.
Did you try to look into any of the nutritional assessment?
Yes, sir. I have assessed the nutritional assessment using the subjective global assessment tools.
Okay. So, what are the components? How many variables you do, and how do you see subjective global assessment?
So there are seven components. There are four components in history and three components in examination.
Yes.
And according to
Go
that,
ahead.
classify it into like well nourished, moderately nourished, or severely malnourished.
Yes. Describe this content because this is very important. In most of the presentations, we are finding, even in exams, boys are not giving any respect to the nutritional assessment nowadays.
Yes. In the history part, sir, we have to assess the weight loss the patient has had in the past and the the status of the weight in the last 2 weeks. Then in the dietary intake, we have to assess the dietary intake of the patient, the disease status of the patient, and the performance, the functional status of the patient. And in the examination part, there are three components, sir. One, we assess the fetal edema, and
That's all.
so there are two more components.
You must know it. I think it's repeatedly we are emphasizing that today's era rehabilitation has come up in GI malignancy in a big way. In a big way, if you see the literature is full in every malignancy, in
Other is,
everywhere. Uh,
the other is muscle wasting and fat depletion.
so you are what functional assessment you see? You are reaching the patient and examining.
Yes, sir.
So what are the functional things you are seeing in LGA?
So we can
Sorry. Yes. Patient is sitting, you are taking history is completed, examination you have done it. Now you want to do some assessment of the nutrition. What are the functional components in SGA? You see bedside.
and for nutrition, we can do head-to-toe examination. We can look at from head to toe, like hair, there'll be features of malnutrition, there'll be brittle hairs, and graying of hair will be there.
No functional assessment you said, na, you'll start seeing it. So do you want to to say something that this particular thing will be deciding this?
So one we can do is the hand grip strength we can measure.
We
And
can nahi, what is done in SGA? Can से कुछ नहीं होगा.
so in SGA we do pedal edema, and for fat depletion we use the mid up the skin fold thickness, and muscle wasting is assessed at three sites.
Uh-huh. And you do in that, is there something you ask the patient to perform?
So in SGA we don't do, but
Uh,
other than that we can do breath holding time. We can ask the patient to hold the breath.
yeah,
And
it's not in the component of SGA, but in the OPD also, so many times we ask the patient to hold the breath.
yes,
You told about 20 seconds in this list.
21 seconds. Yes.
21 seconds. So, what is your assessment of 21-second breath holding time?
This is normal, usually around 20 to 22 seconds. Is normal.
Little bit toward the lower side, yeah. But for
Yes.
Indian population, maybe normal. For a lady of 58, it might be a normal thing.
Yes, sir.
Any other nutritional tool you know for the muscle? For the muscle, which is the best objective assessment? Assessment
We
of
can
the
use
muscle.
a hand grip dynamometer.
Yes. So it is available. So
Yes.
now in PGI, I think we are doing this. We did one. Dr. Harjit was the guide, and we did one that paper is published for the pancreatic tumor, but it can be used for everything, for other GI malignancies also. So dynamometer and
And we can use a psoas muscle thickness also on NCCT. We can assess that.
NCCT. It's very important. You can go and see that these are the things which can document that this patient is had, and that it correlate well with the outcome.
Yes, sir. Yes, sir. It does correlate with.
Okay. So now we have come to so now can you tell your final diagnosis?
Sir, it is my patient is a case of carcinoma esophagus with grade 3 dysphagia
Okay.
with moderately
So,
nourished.
so now how will you proceed?
Sir, I'd like to first confirm my diagnosis. For that, I'll perform an upper GI endoscopy, sir. And
Okay.
so these were the endoscopies which were performed at the outside center.
So
The
do we
first-
know, do you do any preparation to do upper GI endoscopy, or patient coming OPD and you say that go for endoscopy?
So we keep the patient NPO overnight, and then fasting we do the endoscopy.
Mm-hmm. Okay. So before endoscopy, is there any role of barium study?
So usually for patients who have oropharyngeal dysphagia, in those patients we can do a barium study. It provides a roadmap to go ahead with endoscopy. But in this patient, we thought that it is the obstruction is at a lower level, so we can go for upfront endoscopy.
So historically, if you see the CA-esophagus, lots of work has been done by the Japanese. There is
Yes.
no doubt about that. And historically, if you see when we were registrars, it was the norm that you should do a barium because it makes a roadmap. And Yakiyama, you must not be knowing Yakiyama or not read any article. Have you read anything about Yakiyama? So if you see the Yakiyama, based on the barium, they described, seeing the axis of the barium, they described about features of malignancy. And that time, our seniors were very fond of asking this question: what can happen in a malignancy, and what can happen in a something where a nodal compression is there? But obviously, these things have become historical. So usually nowadays, know this thing. But in a patient where you are talking about aspiration, all those things, would you like to confirm that this should not be aspirating when he going to the barium history?
Yes, sir. Yes, sir.
So the patient, the layer fluid level, if there is lots of this thing, you will go and immediately patient put a scope. If you will just put fasting, there is a fluid level and she might aspirate. So I think it is very important to look into all these features. And this lady doesn't have so much, but when you are talking up, these small things make a point in the exams
Yes.
and make average reagent, good reagent, best reagent, like thing a consultant you start thinking when you are presenting in the history. That I would like to ensure that cannot be any aspiration when I'm doing a endoscopy. Sometimes in a eclasia cardia, you can put a rice tube and aspirate and say that there is nothing until nothing in the this thing, so that time there is a cuffing. That time only oropharyngeal short anesthesia is given. Unlike many Western countries where nothing can be done without proper short GA. So all these things are very, very important for the endoscopy. And if there is a history of anemia, it's also important to know the hemoglobin level. So basically, what I mean to say that if you are sending the patient, you should not have a risk of developing anything. So go at upper GI endoscopy.
So the first endoscopy showed a proliferative growth at 26 centimeters in mid-esophagus, leading to luminal occlusion. Scope was not negotiable. However, the biopsy came as full thickness dysplastic epithelium. Then the endoscopy was repeated again at the outside center.
No, so just listen. So how after seeing this, what will you do?
Uh, sir, I would like
Can
to,
yes.
sir, I would like to repeat the endoscopy and take deeper biopsies.
So what are those biopsies called as? When you are doing a luminal structure, when you are doing a luminal structure and there is a growth, how do you take the biopsy?
We usually take 6 to 8 biopsies from the biopsies from the core areas, not from the periphery.
Okay. And anything you can add in the recent nowadays lots of advancement in the endoscopy where you can see the morphology and think that looks like malignancy.
So for early lesions, for mucosal lesions, we have narrowband imaging, which can show some features of malignancy, sir.
So you have seen narrowband imaging in Jodhpur going to the medical gastro department.
I have not personally seen, but they are doing so.
No, but you should go and see once. Everybody should have an idea. I have at least gone and seen. So
Yes.
you must go and see it, and then is there any role of dilatation because everything is very luminal narrowing is there, and probably still in spite of that, she's able to take some food.
The dilatation can be attempted, but it is at a risk. There is a risk of esophageal perforation.
Perforation, yes, okay. So repeat endoscopy showed.
So again, the repeat endoscopy also showed growth at 23 centimeter, and the biopsy showed moderate dysplasia. She was then referred to us, sir. And this was the
Okay,
endoscopy performed at our center, which showed a growth at 26 centimeters, causing luminal narrowing, and adult scope could not be negotiated. And multiple biopsies have been taken. The provisional report is suggestive of squamous cell carcinoma.
okay. So it has come now. It's come as cell carcinoma, and no attempt of any type of tube placement or anything has been done
Since,
at your center.
since patient was tolerating semi-solid diet, we
Hmm.
had avoided any tube placements.
Okay, I will ask later on regarding this tube placement. So biopsy has been done now, and you are knowing that there is a growth at the 26 centimeter. You are seeing this, and now what will you do?
Sir, I'd like to stage the disease, sir.
Mhm.
So for staging, I'd like to do a FDG PET CT
Okay.
for this patient.
So I work in a very small place, and I go into a chest X-ray examination, and patient is there is a suggestive of the multiple nodules in the chest. What wrong I have done?
Sir, I'd like to do baseline investigation, sir. The
Then
baseline.
listen. Then I will go. I am again. I don't have that PET scan at my center. I go running to the ultrasound person. He does a ultrasound, and their liver has a mets. Is it possible? All these things scenario.
It is possible, sir.
So does it make a difference in the approach?
Reduce the cost for the patient.
No. Does it anyway obstruct the management future?
Yes, so we can avoid a PET CT if the patient has metastatic disease diagnosed with USG or.
So the question is very simple, and the answer is also maybe variable. Certain examiners would not be happy with this approach, but since we are working in a government setup, we must know all those things because limited resource country we are. So, and this shows the vision. It's not that you are doing any crime by first saying PET scan. Everybody NCCN guidelines, they say PET scan. 99% of their people are government paid or insurance paid people. So they will say, I will say better metastasis will be better, then I can compare the outcome. But at least your vision is clear. If there is a very simple investigation done in any center, most remote center also have a chest X-ray, and most remote center also have a ultrasound of the abdomen. No crime, but at least it tells that your approach is basic, and you are meant for the common people also. Every center in the country, PET scan is not free. So it cost even in PGI 7,000. I don't know what is in Jodhpur. And outside centers initially they were having lots of costing a lot, but nowadays I think probably because of the competition it has come down. So what I mean to say that X-ray chest in a CA esophagus, you must say first investigation. Somebody might. That's why on upper GI endoscopy I did not say anything because that is our aim that we have to first we have to document that this is a CA esophagus, and then further treatment has to be started. So whenever we are talking in exam, we must look into all these factors so that we don't give a message that we are just like a robot. Every center, every place, and every this thing is different, and we must talk according to the local area center where the patient is, because disease is the one, but person is different.
Yes, sir.
Person comes to which background, from where all these things occur. We must go simultaneously having all these things in the mind when we are asking treatment. Otherwise, your resident now have if you become a robot, then you might not be very beneficial to the society. Academically, you might be very this thing, but society might not benefit as it should from our knowledge or whatever we have. So next, I think you must say ultrasound. This thing. If it comes to CT scan, then obviously it's not a very good staging, but it tells you that metastasis is there or not. Chest X-ray, even if there is a fluid, even if there is a bilateral chest X-ray, suggests that there is a pleural effusion. That also gives one hint that there is something, either aspiration pneumonia, this thing, or there is a pleural effusion which might turn to be metastatic. So all these things will come in one small investigation. Go ahead now.
Then we did a CCT thorax abdomen for this patient.
Uh-huh. So why then you are doing for CT scan, thorax and abdomen?
Sir, actually, the PET waiting time was longer, sir. So, because of that, we had done CT first.
But what will you do?
Sir, usually we do PET CT, but because of the long waiting time, we had to do a CCT.
So most of the time, when you are doing a PET CT scan, what are the advantages over the CT scan?
Sir, PET is more sensitive than CCT in terms of nodal staging and M staging, sir.
Mhm.
And other than that, in most of these patients will receive some form of neoadjuvant.
So Ankit, there are three components of any this type of imaging.
Yes, sir.
Cross-sectional imaging, there are three components. One is T stage, another is N, third is M. In all these three, you tell me the comparison of ultrasound with the CT scan.
CT is more sensitive compared to ultrasound for all the three stages.
Not ultrasound, we are talking PET scan and CT scan.
For PET CT and CT, PET is more sensitive than CT in terms of N and M stages.
So you tell the CT scan sensitivity is this for the nodal disease and PET is this. Same way, in a T stage, sensitivity is this, PET scan is this. For metastasis, CT is this and PET is this.
So for M stage, the sensitivity of PET CT is around 94%, sir.
Uh-huh.
I'm not aware for CT, sir.
So you must have your stage. Your stage. It's very very important to talk very very objective.
Yes, sir.
We as a consultant might get away with talking that this is more sensitive, but you as a registrar, you should have objective. Is that multiple? You see the multiple reports they have mentioned CT scan this for M. It's not good investigation for to see the T only 45-40% sensitivity. So same way we will go for lymph node. These are the things for the metastasis. So if you answer in this manner, then it's a very good way of studying. You should have a knowledgeable. All the philosophical and subjective things are not